Researchers and colleagues, friends, scientists, welcome to lightning session number 2. My name is Mary Beth Ritchie, and oh my, we've got some hecklers in the room. I'm going to stay over here. My name is Mary Beth Ritchie. I am the floor moderator for our session today. I am joined by 3 amazing people who are going to moderate each of these mini sessions. Leah Russo is going to talk to us, introduce all of these folks who are going to talk to us about health equity. And then after that, we're going to talk about target trials, and Robert Platt is going to lead us through that. And then finally, for this session, we're going to talk about COVID vaccines, and Jessica Jalbert is going to help us through that. Nonetheless, for those who are new to lightning sessions, you may have already noticed they're a little different from the norm. Everything is timed carefully. Each speaker will be allowed 3 minutes, including any technical difficulties, to talk about their topic. And then after that, there's going to be an amazing panel session where they're all going to take their research and enlighten us on the larger efforts in that realm. Then we're going to reset the entire room and do it all again, twice more. It's going to be amazing. There are 30 minutes per subsection. And as I mentioned, things are very carefully timed. And so with that, I will hand it over to Leo, and we will get started talking about equity.
Thank you, Mary Beth. Good afternoon, everyone. And I will be very brief. And I'm just going to say that, look, as epidemiologists and pharmacoepidemiologists, we focus on disease and treatments, if you really think about it, and answering why certain people either have an event or receive a treatment. But social inequity has been, it's a part of the puzzle, but it hasn't gotten enough of our attention. And so at this conference here, I can see that changing. And so I'm really honored to be able to moderate this session today on equity. And with that, I will hand over to Julie.
Thank you very much. I'm Julie Smith from Aarhus University. I'll be speaking on genetic variants and social benefit use. And these are the disclosures. So for women with breast cancer, taxane-based chemotherapy like docetaxel is guideline therapy, but it comes with side effects. The severity of these side effects might be affected by specific genetic variants or SNPs, and the side effects might be so severe that they affect the ability to work and therefore the need for benefit use or benefits. So therefore, we investigated the association between selected SNPs involved in taxane metabolism, transport, and toxicity, and the use of social benefits. And we did that in a Danish nationwide cohort study, including more than 2,400 premenopausal breast cancer patients treated with docetaxel. We had genotype information on 21 SNPs in 16 genes. Using routinely collected administrative data on a weekly basis of social benefit payments, we categorize women as either receiving health-related benefits, including disability pensions and sick leave compensation, or receiving labor market-related benefits, including unemployment benefits, and finally, a group of self-supporting women who were either on student grants or not registered with a social benefit payment. Here we see the use of social benefits from 1 year before breast cancer diagnosis to 5 years after, regardless of the genetic variants. And we can see large changes over time, especially for the health-related benefits and self-support. So next up is a volcano plot showing the association between all 21 SNPs and the risk of receiving health-related benefits during 5 time points or time periods. It's a busy slide, I know, but for example, we see that women carrying the SNP in the gene GSCP1 had a slightly higher risk of receiving health-related benefits during the 2 first years after breast cancer diagnosis. However, risk estimates were close to null. And overall in our study, we did not see any strong associations and conclude that there's a limited impact of the SNPs on social benefit use after breast cancer. Thank you.
Good afternoon. I'm Harlan Patel, a quantitative scientist at Flatiron Health, and today I'll be presenting on behalf of our health equity research team from a recent analysis of the implications of structural racism for cancer care and cancer outcomes. I'd like to note the following disclosures. Structural racism is defined as the differential access to the goods, services, and opportunities of society by race. And there are many ways structural racism influences cancer care and cancer outcomes in the United States. And we've listed a few examples on the right-hand side of the slide. In this study, our primary objective was to examine how a neighborhood-level measure of structural racism relates to cancer inequities among patients with 4 solid tumor cancers. To answer this question, we used data from the Flatiron Health Database, which is a longitudinal database comprising de-identified, patient-level structured and unstructured data curated via technology-enabled abstraction. And our study period was 2011 to 2022, and our cohort included over 90,000 patients for this study. The diseases we selected are among the most common cancers in the US and diseases with known inequities in treatment and survival. And our exposure of interest was the index of concentration at the extremes, or ICE, which is a 2-dimensional measure of race and income, which we categorized into nationally weighted quintiles. And with this approach, quintile 1 denoted the least privileged areas, and quintile 5, our reference group, the most privileged areas. Our main outcomes in this study were time to treatment initiation and overall survival, which we assessed using Kaplan-Meier methods and Cox proportional hazards. And for time, I'll just be presenting adjusted hazard ratios, but our results were similar across approaches. These plots present adjusted hazard ratios from our analyses of treatment initiation and survival, and the left figure displays results from our analysis of treatment initiation across all 4 cancers. And across all 4 cancers studied, we found that residents in the least privileged areas was associated with a lower risk of receiving timely treatment compared to residents in the most privileged areas. The right figure presents results from our analysis of survival, and with the exception of lung cancer, residents in the least privileged areas was associated with a greater risk of death compared to residents in the most privileged areas. In summary, our results indicated that patients residing in the least privileged areas were less likely to receive timely treatment and also had a greater risk of death after adjusting for clinical factors. Along with prior research, we demonstrate that structural racism is an important social determinant of health, and outcomes researchers, like many of us in this room, should seek to incorporate these measures along with other measures of SDOH into our analyses. More broadly, our results indicate that efforts to reduce racial and ethnic inequities in cancer care and health outcomes requires public investments in areas that directly address structural racism, and understanding these pathways is essential for designing effective solutions. Thank you. That's the end of my presentation, and now I'll turn it over to Carla.
Great. Thank you, Harlan. So I'm Carla Vossa. I'm a Senior Director Epidemiology at Syneos Health, and I will present an analysis we did on patient diversity and personalized treatment of non-small cell lung cancer. And that I've done this together with my colleague, Jessica Albano. So these are our disclosures. So as for the background, EGFR mutations are known to be overrepresented in females and Asians and Hispanic Latino non-small cell lung cancer patients, as you can see in the 2 bullets below, for example, based on 2 studies. And this, together with the general underutilization of tumor genetic testing, likely leads to undertreatment of these minority patients. So to understand this, we wanted to investigate the use of EGFR inhibitors among non-small cell lung cancer minority patients in the US. And we did this by looking in TriNetX. That's an EMR database via treatment and diagnosis codes. And in this patient cohort, we looked at sex and race ethnicity distribution among those who use EGFR inhibitors, and compared that to the general US population and all lung cancer patients within the TriNetX database. So here you see the results regarding the sex distribution among the EGFR inhibitor users. So on the left, you see all users, and you see that indeed women are overrepresented, with 60% being female and 40% being male. And you can see that in the three graphs next to it, for the individual EGFR inhibitors, afatinib, osimertinib, and erlotinib, you see the same distribution, although for osimertinib, so the one that was most recently launched, the difference was even higher. And when we look at race ethnicity distribution, we see that most, so again, on the left, you see that most patients are white among the EGFR inhibitor users, and only 4% is Hispanic Latino, 10% is Black African American, and then 11% is Asian. And the same distribution can be found among the individual EGFR inhibitors, so afatinib, osimertinib, and erlotinib. But when you compare this to the general US population and all lung cancer patients within TriNetX, you see that indeed the overrepresentation of women was found, and Asians were also overrepresented among the EGFR inhibitors, but the Hispanics were not. And if you look at the Asians and Hispanics, actually they were a lot lower than you would expect based on the literature. Yeah. So this calls for action.
Time. I'm sorry, I needed to cut you off. We can continue this when we get to the panel.
So I'm Jen Eisner. I'm an associate professor at the College of Pharmacy and the Department of Community Health and Epidemiology here at Dalhousie in Halifax. So I'd like to acknowledge that we are in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. And I'd also like to acknowledge the histories, contributions, and legacies of the African Nova Scotian people and communities that have been here for over 400 years. These are the disclosures. I have none, but we did receive in-kind support from these organizations through the MSSU. So our project, the overall aim was to understand the local context and uptake of pharmacist prescribing in Nova Scotia, which began in 2011. And there's specific conditions and situations in which pharmacists can prescribe, like for minor and common ailments, renewals, substitutions. So we used administrative health data to look at various aspects, but I'm going to share two specific examples. So just the general overall uptake, as well as the impact of policy changes and drug shortages. So when we looked at the overall uptake, we found that 1,182 of the 1,338 pharmacists during the study period prescribed at least once. And we found that overall from our study period, which was April 2017 to March 2020, that there was an increase over time. So you can see the average monthly prescribing by pharmacists went up. When we looked at specific policies, we looked at government funding that began in January of 2020 for herpes zoster, uncomplicated cystitis or urinary tract infections, bladder infections, and contraceptive management. And the funding was for all people with a Nova Scotia health card. And so when that policy came into effect, we did see a big increase in prescribing. We only have that little piece of data, but we did see that big increase right away. And when we looked at drug shortages, and this came from our policy maker stakeholders with the team, they were really curious because there had been a number of drug shortages in 2018 and 19. And so when we looked at those time periods for all prescribing, those went up. But again, we saw that went up over time anyway. But when we looked at specific drugs, so angiotensin receptor blockers, which were short in 2018, we saw a big increase in that category, which was likely substitution between one herb and another. We didn't look at specific drugs, though. We only looked at the classes. And we saw something similar with PPIs in 2019. Of note, we did see H2 receptor antagonists were slightly decreased, but there were shortages of various, and there really weren't many H2RAs available. So we think there was a substitution over to PPIs, which is maybe why we saw more prescribing in the PPI category, even than the herbs. So in summary, we saw that pharmacist prescribing increased over time, and it was impacted by policy decisions that affected the funding of the service, as well as drug shortages. Thank you.
So I want to thank the presenters. Really excellent work, and I learned a lot just going through the research. So now we're going to go on to the panel discussion. So for the first question, I'll go on down the line here. Briefly, very succinctly, remind us of your main finding and your conclusion, but then tell us How do you explain your finding? You know, what's going on at the population level? What are the drivers for what you observed in your data? So, Julie.
Thank you. Can you hear me?
Oops.
All right. Well, we didn't really observe much impact of the SNPs on the social benefit use, but I think it's obviously a very long pathway from genetics to social benefits. So I think there's a lot of drivers. There might be a very small effect on the SNPs if we had larger data sets, but it's hard to tell from the current data.
Thank you. Harlan?
So in our study, we found that with patients with the 4 different cancer types that we looked at, across all 4 of these cancers, patients residing in the least privileged areas were less likely to have a timely start of their treatment and also had an increased risk of death. And I think what the backstory behind these results is that at least in the US, there are a number of factors related to structural racism or institutional racism, which relate to health outcomes such as hospital closures or environmental exposures to cancer risks, like where power plants or other environmental exposures are in the US.
Thank you. Carla?
What we found is that there is, despite what you would expect from an overrepresentation of Asians and Hispanic Latino patients using EGFR inhibitors, they don't use it. So either it might be that they don't have access to genetic testing, or it might be that they do not have access to these drugs. But there was a lot of missing data in this, in this database for race and ethnicity, but also genetic testing. So we couldn't test genetic testing.
Jennifer.
So we saw that pharmacist prescribing increased over time. We know that there were decreases in primary care providers beyond pharmacists availability, so like family physicians and nurse practitioners. So it looked like pharmacists were taking up more of the primary care role in providing medications. We found that with that funding, we saw an increase in prescribing for those services. So we think that was increasing equitable access. Unfortunately, we didn't have enough data in our set to actually differentiate the population groups that were receiving it. And the same with shortages. With the funding provided for pharmacists to do the substitution, it was likely that it was improving access as well for individuals. So it may have been improving equitable access as well.
Thank you. And so the second question, I'll start with Jennifer and come on down. And you even kind of set it up. So this question is to each of you, if you had a magic wand and you could do your study again and you had different resources, you know, what would you do differently?
Yeah, that's a great question. So we would love more data, of course. I showed you up until 2020, but we do have another study that's going on that is looking beyond that. We do have limitations within our data set. We don't have a lot of patient variables, but there is work to improve that. So we can't look at a lot of detail around the individuals. We also were using our drug information system. And there's a lot of fields in there that look like they'd be really helpful, like identifying what type of prescribing a pharmacist is doing, but those aren't actually reported. So we did some survey work as well to actually get self-reported types of activities. So I guess part of what I was hoping in the future is that we have a little bit more in our data set that we can actually use to look at this a little bit further.
Thank you. Carla.
Yeah, so for me as well, I'd like to have more data. So less missing data. But also it would actually be nice to sort of move away from race ethnicity and really know the biological factors that lead to different use, different outcomes, etc. Because race ethnicity is only a proxy. In this case, it might be more a proxy for social inequity than for the gene drivers, which we know, which is EGFR, the EGFR mutation.
I think if we had a magic wand in our study, one thing we would do differently is that we use the index of concentration at the extremes, which is a 2-dimensional measure of race and income, to measure structural racism. And I think having a better or more precise measure of that concept would improve our study, as well as also being able to look at a patient's exposure or potential exposure to this concept over their entire lifetime, not just at the point of their initial cancer diagnosis, which is what we anchored our measure to.
I'll join the call for more data. A larger sample size would allow us to look into not just variant carriers, but homozygotes and heterozygotes. And we have a paper from a colleague of mine, Katrine Hjort, showing that homozygotes carriers have a slower return to work for one of these SNPs. So it would be lovely to unpick that a bit more, and also to subdivide, for example, the health-related benefits in the permanent disability pension and the more shorter-term sick leave compensations.
Thank you. So a lot of data-related limitations, which makes perfect sense to me, is not surprising. So now, to your knowledge of what you've just said about the limitations, what's happening in the field? How is this getting addressed? Do you see, you've got your research there, you've got some things that you wish, limitations you had to deal with. Do you see things changing? What do you see? I'll skip around and go with Harlan first.
Great. I think that's a really great question. And I could just talk a little bit about Flatiron, where we're working really hard and investing to add additional area level measures related to social determinants of health, and to data and evidence that we generate, because I think that would help shed light on some of these issues about which particular variables and features are contributing most to these inequities. And it would be great too for other outcomes researchers in the room to just think about whether or not you see these measures in the data that you have access to, and try to incorporate them into your analyses.
Thank you. Very good. Carla.
Yeah, so I think the FDA and other agencies are, of course, working on patient diversity, bringing out different types of guidance, not only to look at subgroups better, like sex and race and ethnicity, but also to have more diversity in the investigators and other groups that are involved in the research. So also at our company, we have a patient diversity initiative, and are working on making trials more inclusive, but also investigators that are working in this field that they are more representative of the groups they are serving.
Great point. I really think that is something that I think that indirectly then will, within data that you see and thinking about it, will have an impact. Julie.
So we haven't identified other studies looking at this particular question, but with funding, we would be able to do that in Denmark. We have the data available, and we have tumor blocks stored routinely. So we could expand this study to look, circumvent some of the limitations I mentioned about study population size.
So I didn't hit the music button, even though you could hear that there.
Yeah, as we're taking this quick dance break, and I know we have one more person to answer this question, and I'm thinking you have one more after this, if I'm counting
Yes.
correctly. Perfect.
All right.
I want to alert everybody here, take your little dance break and come up with your questions.
Okay. Jennifer, go ahead.
Thanks. I would agree with what everybody else said too. Like we need that improvement in the data, and there is a push to doing that. And in the interim, we have been doing like extra studies on the side. So like patient directed studies to actually talk to patients. So qualitative work and questionnaire work and things like that. So we're looking for the same thing, the improved data in the administrative data. So the socio-demographic information.
Great. Excellent. And so last question, but a very important one. I think the most important one. What do the patients in your study need to alleviate the disparity or make things better that you saw? So based on your research, what needs to be done? Julie, I'll start with you.
If I'm allowed to rephrase maybe from what can the patient do to what can society and employers do. There's other research from Denmark showing that flexible working opportunities when women return to work after breast cancer makes it easier. So I think something like that, and also the clinicians to hopefully be able to alleviate some of the side effects, making it easier to be self-supporting afterwards would be really helpful. And yeah, also for us, some researchers help identify who who are at highest risk of not returning to work. There's some preliminary work going on in our group, where we've seen that there's socioeconomic differences in who are able to return after breast cancer. So I think that's really important to identify who needs the extra support.
Thank you. And just to make sure I didn't misspoke, what do the patients need? They're the ones in your study. What do they need? Probably, presumably,
Sorry.
it's no, it's fine. So what needs to be done on their behalf? So Harlan.
I think for the patients in our study, what needs to be done on their behalf is, at least in the US, make it easier for them to access their cancer treatment. And that could be done via increased public spending and insurance to reduce inequities there that could be contributing to this, or on the actual healthcare side, whether that be increased funding for hospitals or increased reimbursement rates for Medicaid or other public payers.
Great. Carla?
Yeah, I echo that. So yeah, patients need access to genetic testing, to drugs. And then we can take the research forward, right? You can look within the groups to see the heterogeneity, for example, within minority groups is still large. So then look at the real gene drivers and the real biological determinants of treatment outcomes.
Thank you. And Jennifer?
Yeah, so some of what we were finding was funded services from pharmacists. So not all services were funded by the government for everybody. There was limitations. So there was some concern that that was an issue. So looking at what services should optimally be funded for improving access, again, with all the limitations with primary care right now, there's just a lot of unattached patients. So how to optimally use the pharmacists as medication experts to help improve that is what we're working on with follow-up projects.
Excellent. Makes a lot of sense. So now we'll go on to your questions. And so I'm assuming there you can either, Mary Beth will bring you the microphone, or you can come to the one in the stand.
Don't everybody jump in all at once, and be sure you don't look me directly in the eye.
I break the ice. Ursula from the Department of Epidemiology in Rome, Italy. A question to Harlan. Did you look at the underlying mortality trends between these, the people living in the deprived areas with respect to the others? Because the mortality results might not be associated to cancer, but just an overall trend.
That's a really great question. In our data, we only had access to cancer-specific mortality, but I think you could do a pretty similar analysis in the US using just census data and looking at area level death rates at the census tract level. And there has been some similar research looking at infant mortality rates, and they found a similar trend where infants born in less privileged areas had a greater risk of death.
Please go ahead.
Good afternoon. Can you hear me okay?
Yes.
Stephen Thomas, University of Maryland School of Public Health in College Park. Wow, what a session. I just love the pharmacists, because the pharmacists stepped up when we needed them during the pandemic. They came out to the community. They came from behind their desks. They came out into the neighborhoods, into the barbershops and beauty salons where we were bringing vaccinations. So when you ask what the patients need, dignity and respect. People showed up hesitant, and they left hesitant, but vaccinated, because we treated them with dignity and respect. As the pandemic has waned, everybody's gone back to their corners. I can't get them to show up anymore for the very things that worked. But the pharmacists still respond positively. So issues of scoping, because you have some of your other professionals that say, well, you don't want pharmacists in this space. What are the implications there? But my real question is about getting rid of race, ethnicity as an identifier. Because in the United States, I can predict your life expectancy by your zip code. So if we don't have race ethnic identifiers, even with their limitations, and we're not ready to use the phenotypes of the genome to determine what are the implications when we have racial residential segregation and all kinds of other ways in which race ethnicity is used to deny people. We're talking about how we can use it to help people. So what is the bridge from our current race ethnicity identifiers to this more biologically relevant? Are we there yet?
And that's an incredible question. Thank you so much for asking. You get 15 seconds to answer it.
Who wants to take it?
No pressure.
No, I would say, look, we know that the geographical component is essential because then you get what's going on with somebody environmentally. We're not there yet, though. And I think it's because it's a sensitive topic to think how much do we differ genetically? You know, most likely is very little. And it's just how do we separate it out? But I agree with you. The zip code part, I would like it much better if we were looking at zip code versus race and ethnicity. And with that, can we thank the presenters?
Please, let's all. Well, that gets us off to a great start. We need all of these people to leave the stage. We need all people for Target Trials to come onto the stage. It's going to be a big deal. I would like to remind the speakers, because Target Trials, people tend to talk a little bit longer because they have some methodology. And I'd like to remind you that this means 30 seconds. This means 5, 4, 3, 2, 1, and I will cut you off. And Robert Platt, over to you.
All right. We're ready to go. If I can get the 4 of you to sit up here. This order is perfect, actually. Todd, you are going to be up first. Our first speaker, I will hand it right over to him, is Todd Miano.
Good afternoon, everyone. And I'd just like to say, if Dr. Ritchie ever finds herself out of work, I think The Price is Right would be like the perfect backup job. So my name is Todd Miano. I'm a pharmacoepidemiologist at the University of Pennsylvania. I'm presenting on behalf of my colleagues, Phuong Nguyen and Charlie Leonard, who led this study. So I'm just one of the middle authors. This study examines a very common practice. No disclosures for this talk. This study examines a very common practice of giving potassium replacement to prevent hypokalemia in patients who are treated with loop diuretics, and specifically furosemide, because this is by far the most commonly used agent in this class in the United States. Treatment with loop diuretics can cause hypokalemia, which can lead to a variety of adverse effects. It has adverse effects on blood pressure and can increase the risk for arrhythmia. And a common practice is to empirically, without evidence of hypokalemia by measuring concentrations, to prescribe potassium replacement to prevent hypokalemia. And in a previous study in a Medicaid population, our group showed that this practice of empiric potassium replacement led to a lower risk of all-cause mortality in a dose-dependent fashion, where the effects were larger in patients receiving higher doses. And so our goal here was to see if we could validate those findings in a different database that had a different pattern of socioeconomic characteristics. And so our target trial was the randomization of patients who have an indication for treatment with furosemide, and on the day of initiation of treatment, randomizing to treatment with either empiric potassium replacement or without. We stratified our analysis by potassium dose at a threshold of above or below 40 milligrams per day. We addressed confounding with high dimensional propensity scores and inverse probability weighting. And in the secondary analysis, we did a prescriber preference-based instrumental variable approach with the primary outcome being all-cause mortality. This table summarizes our results. We had a very large sample size in the low dose subgroup below 40 milligrams per day. We had over 500,000 individuals, about 300,000 in the low dose group. Our findings were somewhat sensitive to the approach, and that's somewhat of a function of a very large sample size and very precise estimates. Any effect that's there is likely small and somewhat consistent with our previous study of no benefit with low dose, some small benefit with high dose. Thank you.
All right, our next speaker is Jia-Chan Hu, and you are. Yeah, okay, there we go. Is that you? There we go. Full screen.
Okay, so good afternoon, everyone. I'm Jia Chen from National Cheng Kung University, and today I'm going to show my study which is about the SGLT2 inhibitors on anemia in patients with diabetes and chronic kidney disease. We use the target trial emulation to conduct this cohort study, and this is my first study and also my first ESB. I had nothing to disclose. And as we know, SGLT2 inhibitors have proved that they have benefits on type 2 diabetes and CKD patients, though there are some studies suggest that they have mechanism related to SGLT2 inhibitors have benefit on anemia, but we still need more study to prove these ideas. So our study is to assess the effect of SGLT2 inhibitors on anemia-related outcomes. So our data source is the Cheng Kung Research Database, which is the EMR in Taiwan. Here is our target trial. In target trial, we modify from CRANDES and DAPA CKD, which is two meaningful randomized control trial that focusing on patients with diabetes and chronic kidney disease in SGLT2 inhibitors. So our eligibility criteria is age over 18 with type 2 diabetes, chronic kidney disease, stage 3 or stage 1 to 2 with proteinuria. Our treatment strategy is active comparison design. So we compare SGLT2 inhibitors with GLP-1RA. For the target trial, we randomize, and our proposed study, we use the PS method with fine replication weights. Also, for the outcome, we're focusing on composite anemia events, which can include the anemia diagnosis and anemia treatment. For follow-up for the target trial, follow until the end of the trial, and the proposed study follow until the outcome event or others event. For a causal contrast, we use ITT and statistical analysis. We're focusing on cost proportional hazard model. Also, we conduct the subgroup analysis. So for results, as we can see, for composite anemia events and anemia diagnosis, SGLT2 inhibitors show a lower anemia risk compared with GLP-1. And in the subgroup analysis, we also show that patients with CKD stage 3 has more benefits on SGLT2 inhibitors rather than the GLP-1RA. So in our study, we conclude that patients receiving SGLT2 inhibitors have significantly lower risk of anemia events. And also we find out in patients with CKD stage 3, they have more benefits on SGLT2 inhibitors. So that's all of my presentation. Thank you.
All right, moving right along.
And while you're pulling that up, there are indeed a few seats in the front, not 30, but a few.
There we go. This is the hardest part, finding the slides on here. I'm going to tell you.
You're doing a great job.
Yes.
Yeah.
For you now, right?
Hi, everyone, and thank you for the opportunity to present one of my PhD projects, menopausal hormone therapy and risk of cardiovascular disease. My name is Therese Johansson, and I'm a PhD student at Uppsala University, Sweden, but I'm also a research visitor at Garvan Institute of Medical Research in Sydney. And this work was in collaboration with Garvan. I have nothing to disclose. So cardiovascular disease is the leading cause of death globally, both among men and women. But there is a big difference between men and women, and that is that women tend to develop cardiovascular disease 10 years later than men. And it increases substantially around the age of menopause when estrogen levels start to drop. So based on this, it was thought that exogenous estrogen administration could actually protect against cardiovascular disease. However, 20 years ago, a big trial was published, the Women's Health Initiative, that couldn't see any beneficial effects, rather an increased risk, especially of stroke. But I think it's time that we take a step back and actually look at the risk of contemporary menopausal hormone therapy in a healthy population of women that just entered menopause. So to do this, we used the Swedish nationwide registers, and we included all women between the age of 50 to 58 years. And we created 126 emulated target trials. And if we look at our findings, we could see that oral combined menopausal hormone therapy were associated with a small but increased risk of cardiovascular disease. And if we take a look at the transdermal approaches, which is the hormone therapy that you administrate through the skin, we saw a decreased risk or no association at all with cardiovascular disease. And interestingly, if we look at the sales in Sweden of hormone therapy, we can see that the transdermal products have actually increased since 2007, while the oral combined products have is pretty stable since 2007. And I think this shows a very important picture, and women will in the future spend a longer time without any hormone production. And it's actually protective against osteoporosis, but also beneficial and treats menopausal symptoms. Thank you.
I mean, since I know Daniela, should I go ahead and just start the timer now?
Daniela is very generously a pinch hitter for this presentation, so there we go.
Okay, thank you. And that was anyway frightening, but you were frightening, so now I know. Okay, thank you everyone for being here today. I do appreciate this full room. My name is Daniela Moga. I'm an associate professor at University of Kentucky, and I am privileged to present in front of this distinguished audience on behalf of our team. But I would like to give special credits to Jimena Oyarzun Gonzalez, who unfortunately wasn't able to travel, but she was the driving force behind this very complex project as part of her doctoral dissertation. I don't have any other disclosures. And I would like to tell you a little bit about this project in the context of polypharmacy and deprescribing. I'm sure all of you have heard it's kind of making buzz lately. It's a very complex process of trying to address inappropriate medication use, address the negative effects of medication use in older adults. The problem is that we don't know very much about the outcomes of medication optimization and deprescribing. Most of our findings come, or the knowledge comes from randomized trials or interventional studies that are either limited in scope or include a small sample, or are limited in terms of what outcomes they look at. Is it more about the deprescribing? Do patients stop medications? Or is it about the health-related outcomes of such an intervention? So we thought of taking on this project with data available from the Center for Medicare and Medicaid Services in the US. Those that are enrolled in Medicare and have medical benefits in terms of the Part D medication management, they also can benefit from medication therapy management plans. So this is what we were looking here, and we had a 5% sample of Medicare beneficiaries that were enrolled in fee-for-service. They were enrolled for age, and they had coverage for medication use and for the MTM program. What you see here in the figure is really a graphical display of how we follow them from enrollment in the MTM plan until either disenrollment or death. Our outcome of interest was all-cause mortality. So in terms of how we measure exposure, we used the information on the enrollment in the MTM plan, but we
used a time varying approach to really evaluate exposure, and we use several scenarios, and I can get into in the Q&A on more details on how we use these scenarios to measure duration of effect after somebody received the intervention. We also use stabilized weights both for treatment and for censoring after follow-up, and did sensitivity analysis to incorporate additional components of the MTM intervention. And this is the results, the conclusion
And
being—
I gotta stop you, sorry.
I think the conclusion is right there, and you can read it to yourselves. Thank you very much.
Ah, there's the trick. You can read it yourself.
So I'll close Daniela's slides very slowly. So if you need to take a look, you're welcome. All right. Close this one too. Here we go. Okay, I've got a few questions for our panel, and then I'm going to open it up to you as well. So, I think the target trial framework is really, well, first of all, it's really popular, as we saw yesterday with the Esteman session. It makes you think a little more in a structured way and a little differently about your study. Can you, and maybe we'll just go from Todd on the way down, talk a little bit about how it made you think differently about this study, or what you did do differently, or what you might have done?
Sure. Two things that I think are very helpful about thinking in that framework is it helps to identify the most clinically relevant questions. Asking yourself, what is the intervention that I would randomize patients to when thinking about comparative effectiveness question or a drug safety question, I think really helps at least me to kind of hone exactly what is the most clinically relevant question to be asking. And then it just really helps you to avoid looking into the future. It's perhaps the simplest way to avoid simple mistakes like a mortal time bias or conditioning on a collider or those types of things. So even if you're not following explicitly I'm emulating a target trial, I think asking yourself that question, what would I randomize or at what time would I randomize patients is very, very helpful.
I really agree with your statement. And actually, for the target trial emulation, for me, it's just like the things help me to think directly. And in my study, we just like modify from Candice and DAPA-CKD, which is already the clinical trial and have been published. So for me to think in that clinical trial and just modify from them to what I want to know, like the anemia outcome, help me to get more directly contract interests. And also we modify from some exclusion inclusion criteria, so fit more for the observational studies.
Yeah, I also agree with the previous speakers. It really makes you take a step back and think really about what eligibility criteria and what people you actually want to include in your study. But I think one specific thing is the time zero, and also not looking into the future and avoiding the healthy user bias, which in my case is very common.
Okay, and in a way, I'll kind of repeat what others were already said, but it was really like that question, and that's so important. And in using existing data to look at deprescribing intervention is quite tricky, because you don't really know whether the intentionality was there, whether it's a matter of a non-adherence versus a matter of really deprescribing medication optimization as an intervention. So I think that's one consideration. And so looking in our data and having something that's more comprehensive as opposed to just the stop of one medication that you can see in claims was an important consideration. And with regard to time zero, we are still trying to figure out how to best define time zero. So if anybody has ideas and wants to share and suggestions, I would happy take any feedback, because that's very tricky with this data, and we are still figuring out, but it's work in progress.
Thank you. Those were all excellent answers. Okay, I'm going to actually go off script for a second because something Daniela said just triggered an idea that I had, which is when I've conducted studies with this target trial framework, a lot of times it turns out that we end up with a much smaller data set than we thought we would have once we start figuring out who we can actually compare. So I maybe if you could comment, and we'll start with Daniela, because you brought this up at the beginning, the data requirements for your study and how you felt when you looked at power and or confidence or the like with your results.
So I don't know the exact numbers, but a rough estimate. So we started with this 5% random sample, and I think our starting point was around 1.6 million people, and our final sample included in the analysis was 95,000, a little over. So it's still a pretty large sample size, but definitely much lower than we had originally. And some of it was driven by enrollment in the MTM plans, but not necessarily that wasn't the only way of, cutting down. We did not do or I'm not aware of a formal power analysis. I think that might, come later, but I think when you cut and you have a very small sample size, that definitely might be something to consider, especially if you have very, wide confidence intervals and it's like, is it significant? How do you interpret the point estimate? I think that would be something to consider, and maybe more guidance from the world of trial emulation would be very welcome.
Yeah, so actually the problem for us was that so few, because what we did was we took every woman who started hormone therapy during a specific month, and then we made a sequence of trials or emulated target trials, but we ended up with too much data almost, or it took a very long time to analyze this data. But we had a lot of non-users or non-initiators, because there was very few women who actually initiated menopausal hormone therapy. But when we did the as treated protocol, that we actually allowed the non-initiators to start treatment, but then you go back a bit more to the observational study design. So yeah, I agree, it's a bit tricky.
So yes, we have to consider about the power, and actually for, I think, choosing the database is a kind of trade-off, because in Taiwan we have the national research database include all the Taiwanese in the database. But for me, I use the Chang'e database because we have to see about the directly the HbA1c, eGFR value, HB value. So we have to choose a database that include the value of the health records. So actually for my study, we include like 20,000 people in our study. So it's, and still see the significance. So I think it's trade-off to choose a very large database, but it doesn't include the data we need.
Fortunately, in our study, we had very, very large sample size. We were using the Optum claims database. And so it didn't really, specifically in this example, impact our decisions a lot. But thinking about the question, I think it's somewhat related to the idea of in clinical trials of, is your question more of a pragmatic question, or is it more of a trying to estimate efficacy question and trade-offs of a more homogeneous population where we're targeting efficacy versus a more heterogeneous population where we're targeting more of an effectiveness question.
Thanks. And now you anticipated and answered my next question, which is very nice, which was one of the things that this framework does, and I assume that many of you like me didn't get into the session on estimans yesterday because it was oversold, but I was just going to ask to comment on different choices of estimands and different choices of pragmatic versus efficacy designs, and how you thought about it in your specific context. How did you think about, you all had slightly different estimands or different parameters that you were looking at. What was your thought process going through getting to the ones that you, ones, like in your case, that you chose?
Yeah, so we estimated an intention to treat estimate and then an as treated estimate. You know, I was lucky enough to jump into the overflow room for that session yesterday, and I found it very thought provoking. And the thing that I took away from it, that if we could go back and do our study again, I think we would spend more time thinking about the treatment strategy that we were targeting rather than the treatment per se. Yesterday, Miguel Hernan was talking about, in our example, a patient is started on empiric potassium replacement. Obviously, likely that patient's going to be monitored over time, or perhaps not, and then response to the monitoring. What would be an allowable treatment strategy and the response to hyperkalemia over time. And so I think thinking more about the treatment strategy that tied back to the estimand of interest is would have been helpful.
Actually, in our study, I present that we use the IPD, and actually we also done the per protocol analysis. And actually, these two analyses get the really similar results. And also for the statistical analysis, such as ATET, and we get the really similar results. So actually, in our study, for this point, did not really influence our outcomes.
Yeah, I unfortunately also missed yesterday due to a canceled flight, but we did the ITT and as treated. And with menopausal hormone therapy, it is, in our case, 50% of all women stopped using that specific type within a year. So, and we had a follow-up of 3 years. So we also did an as treated analysis afterwards to see any changes. And it was pretty similar results, with the difference that we got more narrow confidence intervals in as treated.
So we did the time varying treatment effect, and that was because it's kind of, and that's why we use those different scenarios for exposure duration, because we really don't know how long the effect of a comprehensive medication review will last. How long does somebody benefit from having an intervention as such? So I think in thinking about the future, kind of really fine-tuning that exposure would also help with the estimate. And I think also maybe thinking about what's the best outcome to capture, that might be something that will be then obviously having an effect on the decision with what to measure.
So I'm looking at the time. I have loads more questions, but if anyone has questions from the audience, please think about coming up.
I am happy to come to you, or you can come to the microphone.
Going once. Going twice.
Robert, back to you.
All right. So you've all already alluded to answers to this question across the course of your talks and the Q&A now, but the last thing I want to ask is sort of what's next? Where do we go? Should we all only do target trial thinking if we want to estimate efficacy and safety? Where does this go in terms of, what we could call traditional epidemiologic designs versus the kind of thinking you guys talked about today? What's next?
My favorite answer to this kind of question is also, it depends. But I think really it goes back to like what's the question we want to answer, and whether this framework, at least that's how I look at it, whether this framework is really, I think it really provides a standard way of approaching. And I think, you know, avoiding some potential, I don't know, traps along the way when you have the data available is really important, especially for trainees, but for all of us, because you might miss certain things. So without taking too much time, that's kind of how I look at things.
Yeah, I very much agree with what you just said. One size doesn't fit all, I think, but it really makes you think about the common pitfalls that you usually use. But if you do a really good observational cohort study and you think in the same sense, you take a step back, I think you might not come up with very big differences in the end.
Actually, I agree of the previous answer. And actually, for me, I think really depends on what the research question you are figuring out. Some for the cohort study, it's use the target trial mutation framework can help us to think clearly and get a directly on more specific answers. But for others like case control or other study, it might still need it.
Yeah, very much the same. I think, and if not explicitly emulating a trial, at least asking yourself the question, if you're doing a comparative safety, comparative effectiveness, asking yourself how you might randomize the contrast can be helpful. And I think looking towards the future, another issue is I think there's a role for education outside of the group that does this and understands it. We had a paper that went into review and we were emulating target trials, and the reviewer was like, this is not, you didn't randomize, this is not an emulation.
This was my question. I should have asked my question. It's time for this session to end. I bet all of you, like me, have a lot of questions for these speakers. And so find them later and ask them all your questions. Thank you all for telling us about your target trials. Thank you, Robert. And I think that now it is time for us to move on to COVID vaccines. If you are sitting in the back of the room, there's a whole row up here. People are going to switch in and out. And as we are, quick reminder, we've got 4 presentations. This means 30 seconds. This means 5, 4, 3, 2, 1. And Jessica, over to you.
All right. Good afternoon, everybody. So my name is Jessica Jalbert. Yes, I'm going to be monitoring.
And if you're exiting, please be quiet.
All right. Hi again. So my name is Jessica Jalbert. I'm very excited to be here to moderate this section on COVID vaccines. The room is pretty full. And like many of you, I'm kind of, I have totally the COVID fatigue. But I'm very, very happy that there are still so many people that are staying for this last mini session, because clearly we're not fatigued by the science. So with that, Catherine, over to you.
Good afternoon. My name is Catherine Coe. I'm in the real world evidence work stream at the European Medicines Agency. Those are my disclaimers. So I'm going to give you a very brief overview of the vaccine monitoring platform in Europe, or VMP. So the VMP is a joint endeavor of the EMA and the European CDC, which resulted from their extended mandate under the European Health Union, which aims is to support EU member states to better prevent and address future pandemics. So this work is about identifying and prioritizing evidence gaps in Europe in order to design, launch, register, and supervise studies on the use, effectiveness, and safety of vaccines. This work is conducted by means of independent studies that EMA and ECDC are coordinating using their scientific and operational infrastructure and procurement system. And importantly, one of the aims of the VMP is to timely communicate to EU regulatory and public health decision makers, patients, and the public. The VMP is advised by an EU immunization and vaccine monitoring board on strategy, selection of best data sources, how to conduct feasibility assessment of studies, and importantly, particularly for the audience here today at ICPI, on methods. And of course, it also advises on interpreting the data and on how use it in the regulatory and public health context in Europe. It is composed of representatives from EMA committees, national regulatory agencies, and public health authorities in the member states. This advisory board also has supported the development of a research agenda, which is composed of a variety of aspects. And the first aspect is about identifying knowledge gaps and addressing those gaps. And I'm going to show you a couple of examples of this work. First, in terms of gaps, there is more data needed on special populations that are not studied in clinical trials. The studies might also address the need for additional endpoints, such as for products where effectiveness is lacking because authorization was based on immunogenicity, and of course to monitor long-term effectiveness and safety. Another aim is the continuous monitoring of the benefit-risk profile of vaccines. Again, a few examples. For example, when for a given vaccine, there's a rapid viral evolution or change in vaccine composition, COVID-19 or what else. When additional knowledge is needed on a specific topic, for example, for class effect on certain types of vaccines, again, COVID-19 vaccines, waning effectiveness for acellular pertussis vaccines. Another aim is to support emergency use for new indications. And here the example is, what?
Time is up.
Are you kidding?
Okay, so I am sure we'll have the opportunity to talk more about it. Your time is indeed up, and we'll talk about it in just a couple minutes. Thank you so much.
That's okay. All right. So which one is yours?
That one.
This one?
Yep.
Lightning, right? Lightning strikes.
Yep. This one. Yep. There you go.
Hi there, my name is Bree Goodale. I'm with Julius Clinical's High Data Science, and today I'm going to be talking about the post-authorization surveillance study for mRNA-1273, and in particular, how we overcome some methodological challenges. So disclosure slide, you can read more about it in the handout that provided. In particular, for those of you who aren't familiar, VAC4EU is an international association of institutions in Europe that supports robust and timely evidence generation on the effects of vaccines. And we, Julius Clinical, are proud to be a partner of VAC4EU. So the objective is to really explore the optimal approaches to harmonize multinational observational studies of adverse events of special interest. So how do we go about doing that? Well, for this study, we looked for the methods of observational data taken from 4 European countries and regions, which was then changed and converted into a conception-based common data model. Conception was an IMI-funded study that really set up the framework that VAC4EU uses and leverages to be able to get all of the data sources from different countries, GDPR compliant, and in the same kind of way of variables, labels, et cetera. So the ASIs, we were identified using CodeMapper, which is another VAC4EU tool and algorithm that looks at SNOMED codes, ICD-10 codes, and again, kind of pulls the relevant ASIs of interest. And we then have to develop and test scripts and simulated data. So the first methodology was complex methodology. We had 38 ASIs that we were interested in, and there were different analysis needs alongside an evolving regulatory environment, as this was a COVID-19 specific vaccine study. Technical challenges. So we had 28.5 million individuals, observed individuals in the last interim report. So that's a lot of data to go through. We also had 6.4 million individuals who were vaccinated at least once with the mRNA-1273 vaccine. And then we had a distributed analytics platform. So because of GDPR requirements, we actually could not condense all of the analysis points into one place. Instead, we had to actually go through and create centrally a program that then could run locally at all of the data access providers. This was obviously, with the amount of people, computationally demanding. The server size demand was quite high, so we faced that. And then there was also need for intensive collaboration. So for per data partner, we had different structures, different data availabilities. We could parallelize in some places, not in others. And there were also tight timelines with regulatory folks. So how do we solve these challenges? Well, first, we looked at grouping ASIs in multiple analysis profiles. So we took into account kind of different things that were characteristic of each ASI, and then divided our study up into either a cohort study with historical comparators or contemporaneous comparators. We also had advanced programming techniques like reusable interruption-proof scripts with version control. And we also adopted a task force-based system in part with Back4EU that allowed us to develop simultaneous programming guidelines could be applied across different trials, and also use simulation data to test run stuff centrally before it was put to the depths. More than happy to talk about these things during our panel discussion or come find me afterwards. Thank you.
All right, Lauren, the floor is yours.
Hi, I'm Lauren Peatluck, an epidemiologist at Optum Epidemiology, and thanks for the opportunity to present today. These are the disclosures for myself and my co-authors. And as many in the audience likely know, clinical data such as claims are quite useful for vaccine safety and effectiveness research because they can provide near real-time data in very large populations. However, during the COVID-19 pandemic, many people receive vaccinations outside of our traditional medical system, where an insurance claim for that vaccine would not have been generated. Thus, in this case, commercial claims alone are not a sufficient source of vaccine information for COVID-19 research. Fortunately, it's possible to link vaccine records from claims to immunization information systems, and also known as IAS, and we can use this to enhance vaccine capture. And previous work by my colleagues on the FDA BEST team showed that such linkage greatly improves vaccine capture of COVID-19 vaccines. And so our objective in this study was to expand on that work by estimating the contribution of IAS data to claims-based COVID-19 vaccine capture over time. And so for this study, we used linked data, including data from the Optum database and IAS data. The analysis then included individuals in 12 states who were enrolled at some point between December 1st, 2020 and March 31st, 2023, during which their IAS data was contributing data to our linked database. And with this data, we then evaluated the source of vaccination as being captured in claims only, being captured in both claims and IAS, or captured in IAS data only. So overall, 4.4 million individuals were included in this study, contributing 5.8 million vaccine records. So this table on the left shows the proportion of people in the study who had at least one vaccine record in claims, at least one vaccine record in the linked claims and IAS data, and then the difference in percentages between those two columns. And so from this, we can see that the contribution of IAS data to claims-based vaccine capture varies slightly by age group, with a 2% increase in younger children, up to 21% increase by that IAS data in older adults. The figure then on the top right shows the proportion of vaccine records that were captured in IAS data only with that red line, and then the histogram of each vaccine source across the bottom. And we can see that in the early months of the pandemic on the left-hand side of the graph, majority of the IAS data was contributing a lot to vaccine capture, so over 50% or more. And as the pandemic went on, this decreased to about 30% or less. And so this bottom right figure then shows the source of vaccination. As with the figure above, the red line is for IAS data only, for which we cannot determine the source beyond that. The purple line is pharmacy claims, which we can see begin to increase in April 2021. And then there's a steady increase in black, which is office-based vaccinations, particularly in June 2022, when the vaccine was first authorized for children. Thank you.
Thank you.
Hello, I'm Sylvia Taylor from AstraZeneca. I'm here today to speak to you about relative vaccine effectiveness. These are the disclosures. So Reforço Brazil was a test negative case control study estimating the relative vaccine effectiveness of COVID-19 first booster doses against COVID-19 hospitalizations compared with the vaccine primary series. And we did that using Brazilian national databases. The first database was the National Hospital-Based Surveillance of Serious Acute Respiratory Syndrome. And then the second database was the National Vaccination Registry for COVID-19 vaccines. And we linked the two databases together using a tokenization process. We then looked at the hospitalizations between August 2021 and September 2022. And in matched populations, we were able to identify 13,000 people who tested positive for COVID and 20,000 who had tested negative among those hospital SARS cases. So why relative vaccine effectiveness? So this is really answering the question about what is the additional benefit that a booster dose is providing over the primary series of vaccination. And this is opposed to absolute vaccine effectiveness, which is looking at the total series and looking at the effectiveness compared to an unvaccinated population, which is an increasingly very targeted and rare and demographically exclusive population. And what we know about absolute vaccine effectiveness is that it initially peaks, and then with the COVID-19 vaccines, it wanes over time. So the purpose of the boosters is to take that waning level of effectiveness and boost it to the initial high levels. But what's important here is to note is that means that relative vaccine effectiveness is a time-dependent measure. And in this study, people had received the primary series at least 6 months previously. And so the point we wanted to make here was really about the interpretation of these relative vaccine effectiveness measures because they're not actually very intuitive. So for example, we found that relative vaccine effectiveness decreased with age. And that was really probably because in older individuals, vaccination wanes faster, and then the benefit of booster dose vaccination is therefore more in those populations. But there's all sorts of dynamics that are playing in the background that need to be carefully investigated to understand and properly interpret relative vaccine effectiveness. So we recommend stratified analyses so that those estimates can be properly interpreted and inform policy correctly. Thank you.
Right. Well, thank you so much for your interesting presentations. So all the presentations we've heard, today in this mini session have been on COVID-19, right? So again, as I alluded to earlier, I wish COVID-19 was in our rearview mirror, but it's not, right? So it's resurging. And so it would be good if the panelists could talk a little bit about the research that they've done, the partnerships that they've set up, and how those, the work that's been done in this context can help inform the development potentially of new vaccines. Like, what have we learned? And, how is this kind of pushing us ahead, of not only of COVID, of the RSV vaccines and other vaccines that might be, upcoming. So maybe start with you, Catherine.
And thank you for the opportunity to actually finish my my presentation. And thanks for the question, because this is exactly what this vaccine monitoring platform is about. Of course, it builds on lessons learned from the COVID-19 pandemic in terms of using the right data sources, in terms of using the right methodology. And I really like the example of Sylvia, because it's a very important topic. So we are building on this. In terms of collaboration, it's another very important aspect. There's a lot going on in terms of consortia in Europe, looking at monitoring vaccines. So this is something that is starting now, which is really a collaboration with European CDC. And this is very important because the ECDC can bring the component that is sometimes lacking, which is about linking epidemiological surveillance data. So we're not quite there yet, because we make secondary use of data in Europe. There are those large databases, but sometimes when we look again at COVID, there's an issue with capturing variant-specific data, etc. There will also be several collaborations with academic centers. We have in mind primary data collection, and I mentioned to finish this research agenda that has been developed, which includes research questions on a large number of vaccine preventable diseases for those who don't have yet a product or product in development, but also for routine vaccines. So across the board.
Thank you, Bree.
Yeah, so from my side, the work that we did and the way that we've approached kind of some of these methodological hurdles has really been, as I like to, quote Newton, standing on the shoulder of giants, right? So we were only able to do and kind of analyze and continue to build on and iterate on the work that's been previously done through VAC4U collaboration and then through the conception project prior to that. So I think it's really important to understand that some of these really exciting real world evidence driven questions we can answer, which are not just unique to COVID, I think will come from vaccine surveillance hereafter, do require both creativity, innovation, and kind of this constant collaboration of minds. We're lucky to have really great data access providers who we work with, who help us sometimes too when we think about how can we program this centrally so it performs well on your server versus their server versus their server. So it really has been a collaborative approach, and I hopefully don't see that going away. I will share that the study I presented today was the first of our MR1273 past studies, authorization surveillance studies. We already have another one that's about to launch shortly, and that is already implementing some of these methodological improvements compared to the first. So.
Thank you. Lauren?
Yeah, so I think in terms of the work that we've done and how it can apply to other vaccines in the future, I think COVID was a particularly rude awakening, especially in the US, on how broken the system of collecting data like this are. And in a pandemic situation, tracking a new vaccine that's given via non-traditional means, how we actually capture that information and study it when insurance claims are our main source of data, but when you don't have a vaccine record captured in insurance claims, how you're actually going to evaluate the safety and effectiveness of that drug. And I think that we've been over 2.5 years have set up a really strong foundation for collecting this data and linking the IAS data to claims that I do hope can be a pipeline in the future that perhaps we can use for other vaccines. I presented yesterday on some Mpox use of this same pipeline, and I think there are some additional applications where it could be used in situations where we may not have great capture of that vaccine record within the insurance claims data.
Thank you. So for me, the question I'm really struggling with is when we have these new vaccines or even the next pandemic is how we're going to ensure the infrastructure globally, not just in Europe and in the US, is going to be ready to have the type of infrastructure that's needed to assess vaccine effectiveness. Because one of the things that's happened is that because that data is generated more quickly, in Western settings, which is both a process of the level of infrastructure, healthcare infrastructure exists in these countries, but also because the vaccination programs globally tend to be more delayed. So the Brazilian vaccination program tends to start 6 months, even a year after the vaccinations become available in Europe and the US. And so what it means is that real world evidence that's driving policy decisions globally is really based largely on European and US data, when it's not necessarily the right data to be making decisions for other countries. So hopefully this is a little bit of a call to action of also thinking about other places of data.
Great, thank you, Sylvia. So, the COVID pandemic obviously had, there's a lot of suffering. There were not a lot of, really great things that came out of it, except for, in my opinion, two major things. So first thing is that all of a sudden, people knew what an epidemiologist was, so, all of a sudden I wasn't, nobody was asking about their skin when I told them what I was. People all of a sudden knew what an epidemiologist was. I think that's a nice outcome of the pandemic. I think the other thing that really came out and was very nice is that we really saw kind of the value of real world evidence, right? So because these vaccines were out, because there were medicines out, that were, being put in people's arms or put, that monoclonal antibodies put in people's bodies that had not been approved, and we were able to basically leverage the real world data, generate real world evidence about the safety and effectiveness of these products, I think really kind of advanced the field greatly. But of course, there are many challenges that still remain. I think Sylvia, you were talking about it, from a real world evidence perspective in terms of the data availability in different countries. So I'd like to hear more from your perspective, if you could dig into that a little bit more, and then maybe we can go back this way.
Well, one of the main things, so usually if you're doing these types of studies, you would need like a primary data collection, which, doesn't necessarily lend itself to the timing that you need and also the numbers that you may need to have, a very good level of analysis. And what's missing a lot in these countries is the primary care database. So you don't have that basic data that gives you that population-based estimates. And so the reason why we were able to do this study is we were able to, do it within the vaccinated population. So we need to think of ways that we can, use those types of data resources, earlier to make some important decisions about effectiveness.
Great, thank you.
There are lots of existing challenges, or remaining challenges. And I think particularly with IIS data, which is the Immunization Information System in the United States, which we link to claims and use in our analyses, working with IIS data is incredibly challenging. And we've been working with it for years, and I still have probably more questions than answers about it. And that's because every single IIS is different, and there are more IIS than there are states in the country. And as much as you know about one IIS is as much as you know about a single IIS. And so there's different legal contracts that we must have with each IIS and how we get that data. And so despite it being a really helpful and important source of vaccine information, especially in a pandemic situation, it's not without its challenges, many challenges, in fact. And I think that there's a lot of room for improvement in the structure of how we collect immunization data in the United States, perhaps more mandatory reporting. There are differences in which states require reporting of which vaccines, and which states can provide vaccine for surveillance activities versus research purposes. And so all of the complexities there creates this complication in the system that I think would require people with much more political expertise than myself to actually navigate, but make better for our communities.
So from our perspective, Julius Clinical and our participation in Vac4EU, Vac4EU was started actually just before the COVID pandemic, but it was kind of been a real call to action when the pandemic launched to make use of this new collaborative platform and community, and kind of, in some ways, it's been a putting things into effect, like building as we're trying to implement. And so in that way, it's been a great testing of those resources, but also has allowed us to very quickly iterate and improve on them for future. That being said, there's still a lot of areas where we're trying to understand and grow. I mean, one of the things that we face, for example, in our data access providers is the new variants of the vaccine that come out. How are we considering those? Well, with some data access providers, we know the exact date that it was launched in that country, and other places we don't. So there's unique challenges in that these data sources that we're leveraging weren't necessarily set up for these sorts of analyses.
I would like to go back to the point on primary data collection, because we are in a world where we do a lot of secondary use of data, but for some vaccines, we have to go through primary data collection. And I can think, for example, of the monkeypox, the mpox vaccine, and under the vaccine monitoring platform, there's a large project which embeds both a prospective study, but also uses target trial emulation. And the data is complemented by data using US claims in Healthverity in the US. So learning to use complementary approaches in terms of data sources, but also sometimes of methods. Another point in terms of challenges that we faced was having near real-time data, particularly on safety and effectiveness. And this is an issue because when there's a safety signal and PRAC, which is the Pharmacovigilance Evaluation Committee at the EMA, has to review this and act quickly, then the time it takes to design a study and to have access to timely data, it's very difficult because the PRAC evaluation timeline is very short. So having near real-time data. Some benefits that came out is working on readiness on access to those data sources and making them fit for quickly addressing research questions. And Brianna mentioned Vac4EU, and the EMA collaborated on several studies with Vac4EU. And there's been a lot of work done in this network of data sources to be ready for the next research question on vaccines. And finally, about collaboration, great collaborative work between regulators worldwide. There were studies in early times conducted by different regulatory agencies, notably on coagulopathy in COVID-19 vaccine, in COVID-19 patients. And this data is now being pooled and meta-analyzed so across the world. So going back to the point of potentially also having other countries and other regions.
Excellent. So given that we only have a few minutes left, so maybe we can open it up to the audience to ask questions.
Yeah, thank you. That was a great session. I'm Rosa Gini from Ars Toscana, Italy, and from Back4You. I have a question for Dr. Taylor. So the slide that I see here, this is AstraZeneca booster vaccine.
No, this is any booster vaccine in this population. It was mostly mRNA. We do have the vaccine. I didn't present it today. That was presented at ECCMID, but we have the vaccine specific relative vaccine effectiveness, and it was similar between the mRNA and the adenovirus vaccines.
So, but because my question is AstraZeneca vaccine inoculated to 18-year-old, I mean, to young people? Because that was not done anymore in Europe after a while because
but it was used globally. I mean, that was the most used vaccine globally, and it was used in about 30% of people as a booster dose vaccination in Brazil.
Is there any specific safety surveillance for that? Because there were some safety issues.
Yes, of course. There was massive surveillance globally. Most of the cases of TTS were really reported within Europe. And the reporting of that was extremely low outside of Europe, and despite good surveillance systems also existing globally.
Is there a last question of the day?
Bob Chembright Collaboration. So one of the challenges with the new emerging AESI-X-like myocarditis is to come up with a case definition in a hurry that the people can agree on. So going forward, Catherine, we like to kind of coordinate with the US regulatory bodies as well as the Europeans. Would it be EMA or would it be ECDC, both of you, as we try to plan for the next one?
Well, it's both of us. There's a steering group which is joined. There's an advisory board which is joined. So you can reach out to any of us whom you know, and of course we'll consolidate. Yeah.
And with that,
my mic is cut.
Oh no, we end the session. Thank you all for joining us for today. If you enjoyed this, there's one more shot tomorrow. It starts at 1:30. Our new president is going to be the floor moderator for that session. It'll be much more enjoyable than this one. And if you want to see her get inducted and see two of our moderators and one of our speakers today become a fellow, and several other very exciting things ongoing in 10 minutes. That is when our annual meeting occurs upstairs. If you can do me a huge favor as you're leaving the room, block Rob because he has to sit in the front row and I'd like for him to get there just a touch late. Thanks, everyone.
Thank you.